Apathy is a neuropsychiatric syndrome which is commonly seen in the neuropsychiatric clinics. Apathy is often present in traumatic brain injury patients with substantial impact on the quality of life, and often it's shown closely interact with the rehab progression. As clinicians, as well as in literature, we see three different components of apathy. First one is the affective, and then behavioral, and the third one is the cognitive apathy. But just by the presence of apathy, it can mitigate the positive effects of clinical intervention targeting the brain injuries, repair, recovery, and rehabilitation, hence highlighting this syndrome. Apathy at clinical perspective as well as in literature has often been reported to prevent treatment response to traumatic brain injury patients, which can actually have a significant impact in further worsening the quality of life for both patients, families, and their caregivers. Hence, it is important to address apathy in the initial phase of traumatic brain injury treatment. Given the impact and the burden of apathy at an individual level, at a family level, at a caregiver level, at a clinician level, it is important that any further interventions targeting brain injury recovery and rehabilitation, an intervention need to be kept in mind with the current barriers of rehabilitation as well as to reduce apathy, which can improve patients' access to treatment and outcome measures.
So currently, apathy is assessed with clinical scales, such as the Dimension Apathy Scale. However, these scales are subjective and only allow for monitoring of patient engagement while they're in the clinic and not at home. Our recent research has shown that the decision-making task, where the patient has to make a choice depending on the reward and effort, can be used to provide a more objective measure of apathy. And that task, as shown here, can be gamified to improve patient engagement. So research examining the neuromechanisms of apathy show that there are alterations in the frontal striatal networks as well as in dopamine levels that are important for motivation. So in a study with TBI patients, we see decreased connectivity in the frontal regions that are colored red and blue here on this slide. So decreased connectivity between these regions is linked to higher apathy symptoms. But knowing this, we can actually target these networks with cognitive training to improve the synaptic connections using computerized games that are important at improving goal-oriented behavior, like the kitchen-related VR task. So the patient will have a choice, so you can either choose a simple task with less reward or a more complicated task with more rewards, like the golden gloves and going a level up. And such gamified cognitive games can really stimulate that cognitive control and reward that's important for improving apathy levels.
The decision making, which has been proven to detect apathy in a game-like environment, will be used along with the current apathy scales in our innovation. Our innovation is a continuous multi-dimensional apathy estimation algorithm using online model-based data fusion. This algorithm will be embedded inside a chip within this circuit board, which will be placed into the exoskeleton.
As noted, we'll be using an exoskeleton to allow us to measure and then calculate the biomechanical variables that will fill into our apathy estimation model. Exoskeletons are already currently used in rehabilitation, and they're slowly becoming smaller and more affordable. We envisage that as these systems become more affordable, our model will be able to use more extensively in rehabilitation. The exoskeleton will be positioned on our patients' arms while they perform the VR tasks. Accelerometers, gyroscopes, and force sensors mounted on the exoskeleton will then allow us to determine through biomechanical modelling the variables that will feed into our model.
Design of the virtual reality game and exoskeleton device will be underpinned by motor learning principles, such as goal-oriented practice approaches provided through the VR and exoskeleton device. Optimizing the challenge point of the task, which is critical in motor relearning, will be key to managing apathy levels and patient engagement. This is achieved by enabling modification of the kitchen VR task difficulty and modifiable resistance from the exoskeleton device. Data recorded from the device and filtered through an algorithm to estimate apathy levels will provide clinicians with objective data to make informed decisions about progressing or regressing patient rehabilitation.
A preliminary version of the printed circuit board that sends movement data to wirelessly through the internet has already been developed. The team is now looking to consult with patients and clinicians to help to embed this circuit board into an appropriate virtual reality exoskeleton device. The provided funding will be used to purchase up to 5 virtual reality devices, such that software development can be conducted in parallel with the exoskeleton design. It is envisioned that the device will be completed by the end of 2023, along with the relevant ethics approval to conduct the clinical investigation. The device will then be trialed within both clinics in Townsville and in Brisbane, with the trials to be completed at the end of 2024. The data collected from the clinical trials will then be used to seek additional funding from both Bionic Queensland and James Cook University Innovation Fund for patent and commercialization of the product in 2024. Upon successful conformity assessment, the rehabilitation device will be promoted within hospitals and clinics around Queensland, and by 2025 we aim to have a pre-market of the device in Australia and track partnership opportunities from current local and global rehabilitation robot companies. We believe that our innovative apathy estimation scale can be successful in this current market of virtual reality and exoskeleton rehabilitation robots. Our apathy measurement can help to improve rehabilitation for TBI patients and better inform clinicians about the outcome while ensuring patient compliance to their rehabilitation therapy.